wanted to welcome everybody to today's Family Medicine Grand Rounds. We are partnered with the South Central AHEC, and our mission statement is there for y'all to see. Next slide. So as we go ahead and get started here, if you could just make sure that your microphone is muted. Of course, we want you to be attentive and engaged in the session, and then towards the end of the session, I will put a link in so we can provide feedback to our speaker. Next slide. So today is October 26th, and those of you who are claiming CME credit, that is the activity code. I'll put that in the box here in just a moment again as well. But if you are claiming credit, please make sure that you do so before midnight tonight. When we go to the next slide here, I can go over some additional instructions for those who are new. So on this slide here, you will see if you have not yet registered for credit, you'll need to first send your email address to the toll-free number listed there. Once you've done that successfully, you should then be able to text the activity code for today. You'll text attend and then the activity code to that same number, and that should give you credit. But if you're having any issues at all with that, please feel free to reach out to me. Next slide. Those of you who are claiming credit, make sure that you do check your CME transcript every so often, which can be done at the CME office website listed here. But any questions or concerns, please feel free to reach out to them, or you can reach out to myself as well. Next slide. Also, just as a reminder, those who are members of the AAFP, we do also offer credit through their system for this presentation. So keep that in mind, and feel free to contact me if you have any questions. Next slide. We also always just want to make sure that we are, it is our goal to reach these nationally established physician for core competencies during our presentation. So you can see those listed here. Next slide. These are the disclosures that we just have to make sure everybody is aware of as we get started. But I am going to let Dr. Kraus go ahead and get started here. He is an interim chief medical officer for inpatient services, professor and vice chairman for the Department of Urology here at UT. Also, chief division of female urology, neurourology, and voiding dysfunction. And so I will let him start with urinary catheters, everything you wanted to know.
Okay, and I've shrunk, just so I can see my screen, I've shrunk the other windows, so
okay.
I don't know who's on, and I also wouldn't see any messages. Will you be able to
I
monitor
will
that?
be moderating, yeah. So if anybody puts a message in, I'll be sure to, if you pause for a second, I can let you know that there's a message, or we can look at those at the end, whatever. But I'll moderate.
Okay. Awesome.
Thank
All right,
you.
well, thank you everybody for attending. This was an interesting talk to put together. I actually enjoyed putting it together. Dr. Rowley is one of our residents, and she's actually interested in this area that I belong to, this female urology, neurourology, voiding dysfunction subspecialty of urology. And that's why I actually asked her to be involved in this, not to disseminate the work, but just because it was fairly enjoyable. It's a common thing we get. And I think y'all asked us, I want to say 6 months ago or so, could we give something to you guys about helping you with catheters and when to put them in and management and such like that. So it's more of a useful talk, a relevant talk, it's gonna be less research, more of like practical stuff. So I hope that's what you're looking for. What we'll go over for today is the general indications for a catheter, options for what I call mechanical drainage, because catheter is essentially that, and there's different ways to do it. Catheter care, there's some stuff that goes into that in terms of management, preventing problems. And then when I say infections, we're going to talk about, are they really infections, or are they other problems like bacteria and colonization? I'm not going to specifically go into antibiotic usages, which antibiotic is best, and those kinds of things, because that's really not what that's not the message I'm trying to convey here. We can go into it if we have questions. A lot of this, I think, is going to be more, I'm hoping this will be more of an open-ended discussion. Okay, so delving right into it, what are the indications for a catheter? Basically, the most likely or most common ones that we'll be seeing is retention. And retention can be due to urinary obstruction, probably the most common. Urinary retention can also be due to an atonic bladder. And the best way to describe this is if you don't have urine coming out of the patient, it's either because there's a blockage or the pump's not squeezing. It's glorified plumbing. And that's often how I describe it to patients too. If patient can't pee or the stream is real weak or something like that, it's like it's no different than when you turn the faucet on your plumbing at home. If water's not coming out, you either have a blockage in your pipes or you have low water pressure. Well, the water pressure thing is the bladder contractility, and the obstruction is usually prostate. We'll go into that, but other things. Neurogenic bladder, that's a talk in itself. That can be an indication for a catheter drainage. Functional issues, and then what I call the sick patient. So for obstructive retention, break it down by gender, male versus female, anatomic male versus anatomic female. Most commonly, it's going to be BPH. The prostate became so large, it became obstructing. Other things that can obstruct the male outlet, urethral stricture disease. You can get neurogenic bladder, and there's different reasons but why you would need a catheter for neurogenic bladder. But for the obstructive cause, it's most likely going to be what we call detrusor sphincter dysynergia. And that's where the bladder and sphincter stop working together, and instead they work against each other. What should normally happen is your brain sends a signal to your lower urinary tract, I want to pee. And that causes or makes your sphincter to relax. The valve opens first, or the door opens first, and then the bladder starts the contraction. It's a very coordinated event, and it's in that order, because it would be inappropriate for a bladder to be squeezing against a closed sphincter. So sphincter relaxes first, then bladder contracts. In a neurogenic states, certain neurogenic states like spinal cord injury, some multiple sclerosis and spina bifida, you can get a disconnection there where they're actually working against each other, and the bladder's contracting and the sphincter's contracting at the same time. And it's actually a very dangerous situation. Some urine will squirt out, but the pressure inside to generate that is very high, and some of that could reflect back up towards the kidneys. You get hydronephrosis, you get renal damage. Before we knew about it back in the 60s, this was associated with a very high mortality rate, usually from renal damage and sepsis. Nowadays, not so much, but it is still something to think about. Primary bladder obstruction is rather rare. It's usually a young man's disease. For various reasons, the bladder neck does not relax. Bladder neck and the external sphincter are supposed to work together. For whatever reason, the bladder neck, which is heavily innervated by the sympathetic system, does not relax. Think about parasympathetic, sympathetic system. The bladder contracts by a parasympathetic stimulus or by parasympathetic innervation, and the bladder neck is innervated sympathetically. So if you have, when your bladder is contracting, they work opposite of each other. So the parasympathetic system makes the bladder contract, sympathetic system decreases, bladder neck should open. Some people believe that a primary bladder neck obstruction is a situation where there's an overexertion of sympathetic activity to the bladder neck. In female, there's less anatomic options or opportunities for an obstruction. Outlet obstruction can be due to female prolapse, and I'll show you an image of that in a minute. Iatrogenic, which means I put a sling in someone last week, and this week they can't pee. My sling is probably too tight. Neurogenic for the same reasons that we talked about in men. And then urethral stricture disease in females is rather rare. Stricture disease in men is not, it's not that common, but it's not that rare. It's a possibility, whereas strictures in females is relatively very rare, which is surprising because if you're older like me, you knew of a time when women used to be dilated in the office monthly. That was an old thing that the old urologists used to do. They didn't have strictures. They thought they did, but they really didn't. And we stopped doing that. So these are just a couple examples of causes of obstruction in men. I'm hoping you guys can see my arrow, right? So this is a cross section of a bladder. This is the urethra down here. Nicole, can you see the arrow?
Yep, I can see it.
Awesome. So cross section of the bladder. This is actually a thick walled bladder, but lumen of the bladder is here, connected to the urethra. I always tell patients that prostates look like donuts, with the hole in the middle is where the urine goes through. As the prostate enlarges, it enlarges in a very heterogeneous way. You get all these adenomas growing all over the place, and it causes obstruction of the urethra. If you were scoping them visually, this is what it would look like. This is what an open prostate would look like. And this is what a closed prostate looks like. You can see we call this bilateral kissing lobes because the lobes are trying to kiss each other. The bottom pictures are pictures of a stricture. You can see here endoscopically, the hole should be wide open. It should be the whole caliber. And this is probably about an 8 French or 7 French stricture. Male urethral calibers, 24, 26, 28 French, give or take. That's a tight stricture. It's a pin. We call that a pinpoint stricture. On a retrograde urethrogram, that's what this would look like. Again, the narrowing there, and then it just stops, and you can see there's no problem here, and there's no problem there. I think if I recall, when I put this in, this is a picture of detrusor dyssynergia. Basically, the sphincter is living. Actually, that is a stricture too. I take it back. To illustrate where sphincter dyssynergia would be, it's usually just proximal to the bulb right here. The contrast would come down and it would just stop. For females, the real strictures like I said, it's going to be rare. Slings, you'll know. They said I had a sling last week and I can't pee. From a obstruction from prolapse, this is the best picture I could find. Basically, cross-sectional image again with the front of the patient being on where the arrow is. This is the backside. Pubic bone, sitting behind the pubic bone is the bladder. And you can see the urethra coming down here to the vaginal opening. And here we've got the vaginal canal. And in this case, they're actually having a little bit of rectal prolapse, but not uterine prolapse or anything else. That's okay. That's not going to affect the anterior wall of the vagina, which is what I'm pointing to here. However, if the uterus were to drop down, it pulls the anterior vaginal wall with it, and it causes a kinking of the urethra. And in this case, it's a little bit kinked, but there have been cases where it's completely at a 90-degree angle or even greater. So that would obstruct the urethra and prevent her, or have causes for her to have emptying. Honestly, this often presents with recurrent UTIs because they're not emptying well. They end up having high residuals. They come in for the UTIs on exams like, did you know everything was prolapsing out? No. Or I knew it, but I didn't, I was told I didn't have to worry about it. But in actuality, they were obstructing themselves and they had a high post-void residual, which was the cause of the UTIs. And then in their case, we don't need to put a catheter in them. We don't need to treat their UTI. We need to treat their UTIs, obviously, but we need to fix the prolapse to unobstruct them. Catheter would temporize it, but it's not really the right answer. Atonic retention, basically, bladder's not squeezing. It's going to classically be a neurologic issue of some kind. It can be spinal cord injury, usually a lower level spinal cord injury, can be spina bifida, can be MS, can be all the neurologic conditions that are relevant to causing bladder dysfunction, can be male and female. Other possibilities can include what we call lower motor neuron, or the old terminology, lower motor neuron disease, where the nerves coming out of the central nervous system going towards the bladder into the pelvis have been damaged through some sort of surgery, say typically it's going to be a radical hysterectomy because they go much wider in their resection bed. Vascular surgery used to do it a little less often now because more of the procedures are done endoscopically or minimally invasive. Colon surgery and APRs are not an uncommon cause for retention. Poorly controlled diabetes is the end organ neurogenic bladder, often not uncommon in San Antonio, unfortunately. And we talked about neurogenic, like I said. And there's functional reasons for a catheter. I had a hip surgery and I can't get out of bed, or I'm got cognitive issues and I can't be trusted to get out of bed. For whatever reason, I've limited mobility. Sometimes people think a catheter is a better option for them, or it's easier, which is not an uncommon thing, especially when they're in the hospital. Cognitive dysfunction. Again, part of it is, like I said, decreased mobility. Other is they often don't know they have to leak, or sorry, they don't have to pee and they end up leaking. And they end up coming in again with large residuals, and sometimes we'll buy a catheter. What I call the sick patient, these are the ones that are Often, they're in the ICU, they're on a ventilator, they have decreased mobility for the other medical reasons that they're there, or they need strict I's and O's, and they have to put a catheter in to measure the outputs, which again is a point of contention with me because I don't think it's any more accurate than measuring voided volumes, especially in this day and age. The idea of strict I's and O's in the past, where patients would void on their own, I think we can deal with that better than we used to. UTIs and urosepsis, especially if it's caused by retention, that's a good indication for a catheter. Local wound care. So I don't think I have a picture of it, but there's times when you could have sacral decubitus ulcers and patients are leaking, and they leak urine into their wound, and they cannot get it healed, and they're making no headway with wound care, and a lot of the reasons is because the urine just keeps dribbling into the field. So next question, do you really need a chronic catheter? What else can you do? And the first question, do you need a catheter? In the ICU especially, it's common to basically, they're going to be on a ventilator, so let's put a catheter into them. Or they're on a blood pressure medicine, so we need to measure their I's and O's. In this day and age, because of increasing incidence of CAUTIs, that's really been re-looked at, and it is much better to give them a urinal and have them void into it, or have an external catheter voiding into it. You just have to make sure they can empty, or they can have in and out cathing done, which is actually less risk of infection, just as accurate as measuring with a catheter. External catheter is fine. You just need to make sure that, one, they're emptying okay. So if you've got a guy who's in retention, and you put an external catheter on them, or condom catheter, that's not going to help them. They still can't empty. They're peeing fine, but they're in the ICU because of a ventilator, for example, and you want to measure their I's and O's, put a condom catheter or external catheter on. They can empty themselves and then measure it that way. If you're worried about them emptying, you can always check a bladder scan for a post-void residual to ensure they're emptying. The only other tidbit that I didn't put on here, but you do have to make sure that if you're planning on having a patient use an external catheter for a long time, you do need to make sure that they can hold the condom catheter on. That means they have to have the anatomy be endowed well enough to hold the condom catheter. There is an external catheter for a female. I bring this up because when these slides were reviewed, there was a question about whether PureWick should be listed, or should it be, because it's a trade name. So full disclosure, it's there. I have no relationship with them at all. I put it there because a PureWick is not the same thing as an external catheter for a female. An external catheter for a female is a collection device that's placed between the female's legs, and they basically try and pee into it. It doesn't work very well. That's why it never really gained much acceptance. Usually it'll leak and they'll be sitting in a puddle of urine, so it's not a great idea. PureWick, on the other hand, is, you see the image there, it's a device that goes just outside the introitus, kind of in the opening of the vagina, and it applies a low constant suction. Not enough to cause any tissue damage or anything like that, but enough that if any urine comes out, they basically will get sucked into the device and it gets accumulated in the can. You can see pictures of the condom catheter again. For the patient who's ambulatory and just can't pee, ambulatory and is able to pee, maybe they had a catheter in because they had leaking. Condom catheter is a good way to manage it. Putting a catheter in because of leaking, there's other ways to handle it. All right, so the goal of that last slide was make you think about, do you really need an indwelling catheter? And if you do, okay, so then what are our options? A urethral catheter obviously is what we're all accustomed to, but I would argue that when a urethral catheter is indicated, when at all possible, clean intermittent catheterization is a better option. It is a harder option for the patient to agree to. Initially, oftentimes they're reluctant. The idea of having a catheter in and out multiple times just does not do it for them. They're afraid, they're worried they're not going to be able to do it. They're concerned about discomfort. I would argue that it's less risk of infection and it's much better quality of life. We'll go into it in a little bit. It's a lot easier than people think about it. If they have to have an indwelling catheter, then again, it's a urethral catheter, or a suprapubic tube is another option. There is some evidence, we'll go into it, that it might be a better option for you than a urethral catheter. Depends on how long you're expecting that catheter to be in as well. And then when all else fails, nephrostomy tubes would be the ultimate last resort. So urethral catheters, again, most commonly performed, easily placed through the meatus, can be male or female, doesn't matter. Can be for short-term or long-term. For those who are not familiar, catheter has a balloon on the tip of it. The balloon will inflate with anywhere from 5 to 10 cc's to up to 30, depends on the type of catheter you're using. Once the catheter is in, the balloon's inflated. Once it's in the bladder, and then that balloon prevents it from coming out. There are different size catheters. For adults, we typically start with a 14. We typically use 16. You can go as low as 14. You can go lower, but then the smaller the catheter, the smaller the lumen on the inside, which makes urinary drainage harder. There's other reasons why you shouldn't go smaller. We'll talk about placement of a catheter in a minute, but you can see the cross-sectional image, and no one's ever paid that much attention to it. This is basically what it looks like. Catheter goes in, balloon's inflated. You always want to make sure that that balloon is in the bladder before you inflate it. We get very frequent consults where the catheter was not all the way in. Imagine the balloon was in the prostate before it was inflated, and when they inflate it, they're basically creating a balloon dilation of the prostate. Number one, it hurts. Number two, it causes significant bleeding. And number three, it clogs up the catheter, so they don't usually drain very well. So the best way to know that is when you place the catheter, we usually use the term, make sure you hub it. So the catheter hub, which you see here, is advanced. The catheter is advanced all the way through the meatus, all the way into the penis until you reach the hub at the meatus. If the catheter, if you had no resistance, then you've got a lot of extra catheter now sitting in the bladder. You blow up the balloon, and then you slowly withdraw the catheter back out, and the balloon will lodge at the bladder neck. It's a classic feeling, and you'll know you're in the right spot. So what kind of catheter issues can we have? Well, first, difficult catheterization, which might be an indication that you need a urologist, but many times it's not. And I say that, I'll be on my soapbox for just a second. There's so many times when someone said they had a difficult catheter, and then they call you urologist in, and we come in, and it was like nothing. There was nothing special at all. It could be because the catheter that was used was too small. And I understand, I know everyone's trying to be good by the patient. It's like small catheter probably hurt less. It actually is worse, especially kind of when it comes to a male. The smaller the catheter, the less girth it has. As the catheter is going through the urethra and approaches the level of the sphincter and approaches the level of the prostate, you will meet some natural resistance. It's expected to be there. The smaller catheter doesn't do well with that resistance, and instead it will bend or kink or turn on itself. And then you'll feel, oh, I'm not in the right spot and I can't advance it. So that's the problem. A lot of times, if you tried a 14 French catheter in a male, had you tried it like an 18, we'll go up in size. We'll go 18, 20. It'll slide right in. But bigger is not better. Smaller is not better. Difficult to pass the catheter. Also, it's not ideal for drainage. And if you do get any bleeding, it clogs up the catheter too quickly. Things that can cause difficult catheters: larger prostate, stricture disease, obesity, a buried penis. Buried penis is that we see it with obesity. Basically, we're going to be pushing and pushing on the belly, on the pubic area, until we can get the tip of the head of the penis to show itself, and then we just catheterize. So if you do have that difficult catheter placement, what can you do? Yes, you can certainly call urology. We'll be happy to help. But there are a few things that you might be able to do on your own before you call out to us. First things first, make sure you use a lot of lube. Number two, especially if you're doing it in an older male where you think prostate problems may be there, go to a larger size catheter. Classically, the kits come with a 16. We'll go 18, 20, no problems with it. I was once, I could never find this written anywhere, but I was once taught that the adult male urethra is 28 to 30 French. We can pass a 24 French scope during a TURP or resection of a bladder tumor without much fanfare at all. So if you go to 26, we'll dilate a little bit. So if a normal urethra can accommodate a 24, 26 French size, you can easily place an 18 or 20 if you had to. Some catheters are more rigid, or some catheters are more flexible. I would argue especially on the male, the flexible catheters are going to hit that normal resistance and kind of start backing up a little bit, or kinking. Coude catheters are our next go-to, and there is some fallacy that a Coude catheter can only be placed by a urologist. Again, we're fine placing it. If you call us, we can do it. But a Coude catheter does not require any special skill. It just has a curve on it. You can't hurt anybody with it. If you want to optimize the use of the Coude catheter, if you think about the male anatomy, the urethra kind of makes a turn up as it's going through the bulbar urethra and going through the prostate into the bladder. So what we do, this is our little secret, is you make sure the Coude catheter is a curved tip catheter. That's basically what it is. You make sure the curved tip is facing up towards the ceiling, assuming the patient's lying on their back. You make sure the Coude catheter is pointed up towards the ceiling. Most Coude catheters, the hub that you inflate the water in is in line with the curve. So if the curve is facing up, the hub is facing up. And this way, while you're passing it, if you don't see the tip anymore and you're worried that you might have lost it, you can just rotate it a little bit here and there until the tip is facing up again. Again, confirm the position of the catheter before you inflate the balloon. Hub the catheter, as I mentioned earlier. It's even better if once your catheter is in, you hub it and you start seeing drainage. If you're not sure, you can slowly start to inflate the balloon. If the patient feels any pressure, stop, because you might be in the prostate. You can always irrigate the catheter, get a TUMI syringe, and just try and flush it. If your flush is easy, you know you're in the bladder. More advanced options, especially like a urologist, we would scope a catheter in. We would basically get a flexible scope. And obviously, if you've tried the other things, that's what we're going to go to. If you've just tried a 14 or a 16 French and you haven't been able to get it in, we'll probably try a larger catheter or a Coude first. So again, if in the ease of the patient, if we're going to be doing that first, we'd be happy if you tried it. If not, we'll do it. And if we can't get that in, then we would go to a scope, flexible scope. We basically can scope our way through. If we see a stricture, we'll pass a wire through it and then dilate it. If we don't see a stricture through it, if it's just a sharp turn or a big prostate, the scope itself is more girth than the catheter. It'll steer through the prostate. Once we're in, again, we'll pass a catheter in over a wire. The old days, we used to do something called filiforms and followers, and that was basically placing this long, very narrow, solid tube into the urethra until you were in the bladder. You would do it by feel. And if you got to a place where it wouldn't advance, you were like, oh no, I'm in a false passage. So I made a hole, or there was a hole created. Typically, we do this when someone had tried to put a Foley catheter in and created a false passage and then couldn't get in. You keep putting these little filiforms in. The next one goes into the false passage. Once the false passage lumen is filled with, there's no place else for it to go, the next one's going to go into the bladder. And once it's in the bladder, it's got a little screw on the tip of it. You can screw a device onto it, and then advance the catheter over it, and then you pull the filiform out. Another option, suprapubic tube. Most of the time, if patients had previous surgeries, we prefer to have the interventional radiologist do it, but it is something that we can do at the bedside. If they don't have too complicated of a pelvic surgical history, if there's no surgery, the bladder sits in its own pelvic cavity. The peritoneal cavities should be above the bladder, especially if the bladder is very distended. I should be able to poke a needle under local into the bladder, just over the pubic bone, without really fearing that I would hit anything else in there, like intestine, because the bladder is so distended and because they're technically in separate cavities. But if they've had previous surgery, they had colon surgery, the previous bladder surgery, then there's a risk that the colon could become, or any intestine could be dropping between the skin and the bladder itself. And if I try and put a needle through there, then I might hit it. Hence the reason for getting interventional radiology. Other issues or other reasons, hematuria. In this case, again, bigger the catheter, the better. If you put a 14 French in and they're bleeding a lot, they're just going to clog it off, and you're going to require frequent irrigation. So we'll start 20, preferably 22 or even 24. And then if we are really worried about continuous bleeding that's clogging up the catheter, we'll do what's called a three-way catheter, where the catheter has irrigation being flushed in through one of the channels, The other two channels, one is for blowing up the balloon and the other one is for the drainage. I would ask, I mean, obviously everyone can do what you want in terms of being comfortable, but we had one patient where we were consulted on a couple of years ago. And there was a patient who had a three-way placed by the primary care service team, and they hadn't recognized that the catheter actually was clogged and the bladder was being filled with water and it actually ruptured the bladder. So I would argue if you think you need a three-way catheter, we're happy to come help. That would be a good indication for us. Which then leads me to hematuria, since I'm going to take a little sidebar off that. First, it always, and I mean always, looks worse than it really is. You can see in the cups there, you can see what's in the tube in the bag there. It's rarely, and I really mean rarely, a cause for anemia, except for maybe the one in the bag. If you've got, best way to describe it is by food coloring. If you've got a blush color wine urine, if you can see through it, you're not losing a lot of blood. It looks like you are, but you're not. It's kind of like if you ever cut yourself shaving or was bleeding in the shower, you look down the floor, the mix of urine and the water, you think you're bleeding to death, but you're not. It's one drop of blood, one or two drops of blood will turn it that pink color. So usually we just tell the patient to hydrate a little bit more and it'll clear by itself. It looks like cherry Kool-Aid where it's really red, but still watery. It's probably a little bit more bleeding, probably still not a cause for anemia. That one's a little bit more worrisome because it could progress. And if it progresses, now you're talking about clogging up the catheter. So we usually tell our patients to just drink more. And if it doesn't clear, then that's a phone call or, come in to see us. It's thick, looks like tomato juice, which is what you see in the picture there at the bottom. That's the kind of bleeding, that's the kind of hematuria that's a significant amount of bleeding that can cause anemia. Typically, that's going to be something like a bladder tumor or some sort of cancer that's caused bleeding. It can be catheter trauma or some sort of other kind of trauma. But, I say this because we'll often get calls like the hemoglobin's 9, they have hematuria. It's not, the hemoglobin of 9 is not from microscopic or even mildly gross hematuria. It's just not going to be the likely source. Other options for a catheter. Let's go back to catheters. Clean intermittent catheterization is probably the best. It has the lowest risk of infection. There's plenty of data that supports that. It's a better quality of life. If someone's going to have to keep a catheter in for mechanical drainage because for whatever reason we can't get them peeing again, they're either not a candidate for a TURP or they're too sick to have it done, or for whatever reason, living with a chronic catheter versus teaching them how to do in and out cathing. In and out cathing is such a better quality of life. They don't have a tube draining from them 24/7. We can teach them how to do it where they actually do it in a public restroom, both men and women. For women, it's a misnomer because they're usually taught how to catheterize themselves in other offices, other places, and they get these long normal catheters that we've been looking at all throughout this talk. Whereas a female catheter, true female catheter, is very short. It's about 6 inches, maybe, not even. It's rigid. They can hold it with one hand and you can cat themselves while sitting on a toilet. And once they cat themselves, the urine goes straight into the toilet. And then when they're done, they just discard it and they're off on their rest of their day. So we can teach them to catheterize themselves in a public bathroom. I've had women who didn't want to learn in and out cathing because they were afraid it was going to basically tether them to their home. And that's not the case. If you've got someone who's in retention and you're going to have them do in and out cathing, the only thing we would want, and this is again where the urologist would be involved, is we want to make sure that in between the catheterizations, their pressures are safe. So if that patient had a high pressure bladder because of neurogenic bladder, for example, that does put them at risk for a protracted kidney disease, kidney damage, hydronephrosis. If that patient had a chronic catheter in, that risk is obviated by the fact that they're basically being vented all the time by a chronic catheter. But I recommend those patients do in and out cathing so they don't have to deal with the catheter and they don't have to deal with the infections associated with the catheter. But in the meantime, in between the caths, we just want to make sure the pressures are low. I can assess for that with what's called a urodynamics test. If their pressures are high, usually bladder medications, the anticholinergics, the beta-3s, or Botox, another option. That'll lower the pressures fairly well to the point where they can go 4, 6, even sometimes longer hours, and then they cath in that interval, and then they're not leaking in between. Oh, lastly, if you do have someone who's hopefully transiently in retention and you put a catheter in, how do you know if they're going to start, if their bladder wakes up or if they're able to start peeing again? Well, you have to take the catheter out. You have to see if they pee. And if they don't pee, you have to put the catheter back in. Whereas if they're doing in and out cathing over a few days, you may know, oh, I'm able to start peeing now. And every time they pee, we would have them measure in our office, we would have them measure their voided volume, give them a urinal. And then when they cath, you have them pee, measure the voided volume, then they can catheterize themselves and they get a post-void residual. And now I can tell when they're voiding successfully enough that they can stop doing the in and out cathing again. So it's a better quality of life, less risk of infection, offers me more opportunity for care. Okay, so you got the patient who cannot do in and out cathing, refuses, or doesn't have the dexterity, or for whatever reason, and you have to leave a chronic catheter in place. Suprapubic tube is an option, and it may be a better option than leaving in a urethral catheter. Again, we would be ones making that call. Happy to have you make that call too. It's a discussion with the patient. Interventional radiology can certainly do it for you, but it's still a chronic catheter. So the risks and concerns of having a chronic catheter are still going to be there. It does require a minor procedure to do it. Like I said, in my office, if the patient's got basically a virgin belly, I'm able to do it in the office. They sell a kit for it. I numb them up, you can feel where the bladder distension is, and then we basically stick a very narrow needle into the bladder to make sure we get urine back. And once we know that, we can convert it to a wire and then dilate over the tract, put a catheter in. Once the catheter has been in for a couple of weeks, that tract is matured, and basically just take the catheter out every 4 weeks and change it. The other rationale for suprapubic tube is it is more comfortable. There is a question of a lower risk of infection, at least in the neurogenic population. It's not zero risk. It might be a little lower than the urethral catheter risk, but then there's other reasons to do it. I'll show you in a few minutes. Last but not least, nephrostomy tubes. Again, this is a supravesical diversion. We're diverting the urine before it even gets out of the kidneys. These are done by the interventional radiologist. It's an invasive procedure, and it's much higher risk than a suprapubic tube. And in this case, they can do it with fluoro. They can even do it at the bedside using a portable ultrasound machine. They like fluoro preferred, but this is not a without risk procedure, because living right around the kidneys, especially if they've had previous surgeries, there's risk for bowel injury. There's certainly risk of kidneys bleeding. Kidneys like to bleed a lot. And depending on where that tube is placed into the kidney, the chest cavity can drop so that it's level or even lower than the top of the kidney. So when the radiologist places the needle into the kidney, they could be traversing through the lowest aspect of the pulmonary cavity, and then that causes risk for pneumothorax. Again, it's usually a last resort. We don't do it that commonly for retention. We'll do it if there's severe bleeding in the bladder, and we just want to divert the urine away. And basically, we've tried to stop bleeding. We couldn't, no matter what we did. So we'll divert the urine away with the nephrostomy tubes, and then their bladder just fills up with clot and then eventually tamponades. Other reasons for doing it: urethral obstructions, other malignancies. Again, we try for urinary diversions. It's not that common. We will place them for stones fairly commonly, especially when you have an infection stone or stone associated with obstructive pyelonephritis. Nephrostomy there is our best friend. It's the preferred option just because it's very quick. You know the urine is draining. When their infections don't get better, if they spike a fever if I place a stent, which is the other option, and they spike a fever tomorrow, I'm going to scratch my head and I'm going to say, I hope that stent is working. It should be working, but I can't tell. If I have a nephrostomy tube in place and they spike a fever tomorrow, is my nephrostomy tube working? Maybe it's not. Well, just look at the tubing. If you see urine coming out of it, you know it's working. The stent can be dislodged and such. There are some urologists that prefer to place stents for infections. It's a personal thing. Depends on the size of the stone and the situation. I wouldn't say it's all or none. But again, same issues with the chronic catheter. No matter what, you're going to worry about colonization, bacteria. Now you got 2 bags that you got to deal with, so worse quality of life. And this has to be changed usually every 3 months by interventional radiology. Catheter care maintenance. So make sure the catheter is in position. The bag should always be below the level of the bladder to ensure that it's draining properly. Avoid when when patients are supine or lying down, trying to avoid the catheter tubing is lying under the leg so you don't kink it or obstruct it. Always secure the catheter, leg strap, leg bag, whatever you want to use. That catheter gets tugged on, it's going to cause damage either at the meatal, the penile meatus or the female urethral meatus. And especially when these patients have neurologic diseases and neuropathies, or if they're not cognitively fully there, they may not know or not feel that they're being tugged on. And the next thing you know, you're causing tissue damage because the catheter is being ripped on or being torn, tearing the meatus because the tension is being placed on it. Catheter care is not complicated. Everyone thinks it's something special. I'm crazy. Cleaning the genitalia with soap and water, and mild soap and water is the only thing you need. There used to be a thing about using antibiotic ointment at the tip of the meatus. That's not been shown to help anything. Just clean it, and regular soap and water is fine. The bag is, it can be cleaned. The problem is patients with chronic catheters will usually clean it themselves. The old school used to be just flush it with soap and water. Maybe you can use some vinegar and water if it's got a smell to it. The question, or the debatable thing here, is that you are now opening a closed system, and that's the concern for infection. The problem is that a patient who's got a chronic catheter, if it's going to be in long enough that you have to worry about cleaning the bag, they're colonized already. The closed system is probably worthless because they're colonized all over their urethra and bladder. That it's not, the closed system is not sterile anymore. So I am going to put some pictures up of what happens when you leave a catheter in a urethra meatus and it gets tugged on. I say that because they're not good for lunch if you're eating lunch. So stop eating. Bear with me. It is something this is the reason why we always check when you have a patient who's living with a catheter. It behooves us to check the catheter once in a while and make sure that they're not doing what I'm about to show you. In our office, when we have patients who have chronic catheters, our RNs are always checking, or nurses are always checking the meatus because we taught them to do it. And I will see, once the catheter is in and the patient's living with the catheter for the rest of us, I don't need to do much to them, but I still see them once a year to make sure that the following doesn't happen. So this is someone who has a mild, we call this traumatic hypospadias. It tore the opening. The best form of management is what you see here. If they have to have a catheter, get the catheter out and put a suprapubic tube in. This is mild. This is getting worse. And this is really severe. This urethral erosion is almost down to the penile scrotal junction. And that's just not good. Now, everyone's looking at this and probably making faces and saying, how could that let that happen? These patients are usually, they have so many other medical problems. They've got neuropathies. And I venture to say the picture on the right, probably either a spinal cord injury patient or a diabetic with really poor sensation, and did not feel this happening until someone noticed it. And shame on the caregiver for whoever was putting that catheter in for not noticing that this was happening. The same thing can happen to female urethras, though it's not doesn't look the same, obviously. So on the upper left picture, you'll see here, this is the kind of urethral meatus has had a catheter in for so long, and this patient is probably leaking around the catheter. So what does everyone like to do? They say, well, if they're leaking around the 16, that means the urethra is too big, and that's why they're leaking around it. Let's put in a bigger size catheter, and they go to an 18 and a 20. I told you earlier, bigger is better. Well, not in this case. Bigger is not better. Because let's say you put in an 18 and all of a sudden they stop leaking for a little while. And then they'll dilate around it again and they'll start leaking again. That's just what's going to happen. The better option is to figure out why they're leaking around the catheter and fix that problem. It's a lot of times it's bladder spasms. So we have bladder medications for that, or make sure the catheter is not being clogged, because that's often a problem. The catheter gets kinked or bent, the tubing gets bent, that will cause the urine to back up, and then they're leaking around the catheter because their bladder's full. And then that leads us to put in a bigger catheter. And the next thing you know, picture on the upper right, and then the picture right below it is the same picture. You should not be able to put your finger into someone's urethra just like normal. And then the last one, the erosion is so bad that what you're looking at, the dark pink, is the actual bladder mucosa. So all bad. This I can still potentially fix. This I cannot. This one is so bad. Basically, the only way to fix it would be to close the bladder and put in a suprapubic tube so the urine comes out through the suprapubic tube. And that's if there's enough bladder neck left. If not, then they're getting a conduit, a diversion. All right, sorry for grossing everybody out. Catheter care, that was one of the other comments about requested. So typically, how often do you change the catheter? We change it classically every 4 weeks. That's where most of the patients. Sometimes we'll change it to every 2 weeks. Usually we reserve a 2-week change for patients who keep coming in with recurrent UTIs or catheter clogging problems is another. The rationale for doing 2 weeks is it takes about 10 to 14 weeks to form the biofilm on the catheter. So the thought is they'll start, if you change it, would be right around the time the biofilm forms, you'll decrease your risk of getting true infections, which is going to be what we talk about next. Just make sure I'm doing okay on time. Recognize that everyone with a catheter, even if you're doing in and out cathing, but certainly if you have an indwelling catheter, everyone will have bacteriuria. It's related to the colonization of the urinary tract. Bacteriuria does not mean infection. And that means that they will usually test positive on a UA in a culture, because the UA in the culture is not testing for actual infection. It's testing for the presence of bacteria. And if you have bacteriuria, you're going to get positive tests. So it's going to test positive even when they don't actually have a true infection. And to me, that's a worthless test. And the reason this becomes a problem is because they'll come in, see their primary care providers, they'll go to the emergency room, they can go in with a hangnail. And, oh, by the way, did you know your urine is positive? We're going to treat you for that. And we'll put you on an antibiotic. And the next thing you know, they're resistant. That happens enough times, they're resistant to every oral antibiotic. And then when they do get a urine infection, or any infection for that matter, then they really have, they're in a heap of trouble. They got to usually be admitted or have some sort of infusion therapy or infusion service for IV antibiotics. It's just, in our world, if you have a chronic catheter, we tell patients the presence of a positive UA, even a positive culture, is not adequate enough. You have to have that and symptoms of an actual infection. Classically, in someone's chronic catheter, it's fevers, chills, or blood in the urine. The best analogy when I'm talking to patients is, you have bacteria live on your skin. You have skin on, you have bacteria living on your arm. You don't treat it just because they're there. You treat it when you have bacteria present and enough bacteria to cause an infection. My biggest worry is the patient who comes in with a fever of unknown origin or septic, the chronic catheter, and they're like, well, the urine's positive, so that's got to be it. When in reality, my worry is that they're missing another cause. So just bear that in mind. I'm not saying, obviously, you can get infections from catheters, and classically, it's going to be because the catheter clogged or the catheter kinked, the urine stopped draining, and all that colonized urine now has a chance to, grow. The density of the bacterial growth increases, concentration gets higher and higher to the point where now you actually get an infection. When you get a chronic catheter, that's the first thing. When we get a chronic catheter, that's the first thing we do is make sure that if they're getting true infections, that the catheters are draining. The problem patient's going to be the one who comes in who has a chronic catheter, and they're told that you're having UTIs because that's what's causing you to have mental status changes, abdominal pain, nausea, and vomiting. I know that is a known entity, that especially in the older patients or demented patients, that mental status changes is sometimes related to a UTI. Problem again is there are a lot of other things that can cause those problems. And when the urine test is always positive because they have a chronic catheter in, you're probably not treating the actual problem in my book. I'm not saying to ignore the urine at all by any means, just saying think about other sources as well. So bottom line, the most important statement in a patient with a chronic catheter, or even if they're doing in and out cathing, it's less risk of infection, but it's not zero risk. in that patient with a chronic catheter or doing in and out catheter, do not assume a positive urine test is a real infection. And if that urine test is positive and they're completely asymptomatic, please don't treat it. So you're convinced that you need to treat this, despite what I just said. Confirm they're having true infections. That means positive urinalysis, positive culture, and symptoms, not just a positive test. Ensure that that catheter is draining okay. Change the catheter if it hasn't been changed recently, and then consider options for alternative drainage. This is what I was referring to with infections. I'm not gonna, y'all know how to treat infections. You probably do it more than me, and I'm a urologist. But how do you deal with these patients long-term? Change the catheter, if change it more often. Like I said, every 2 weeks, we do for some. Consider alternative options than a chronic indwelling urethral catheter. In and out cathing is one of the things that we would do. Maybe they can be peeing again. That would even be better. Consider the SP tube maybe better than a urethral catheter for a risk of infection. There is evidence, not great evidence, but there is evidence that says that's true. If they're not emptying well, just getting rid of the catheter. So I have this is a soapbox one as well. I've had patients who had chronic catheters in, had them taken out. Either an external provider or some family member said, "Oh, I read somewhere that you have an increased risk of infection, so you should get rid of that catheter." Okay, that's true if you're comparing someone who voids and then someone who voids with a catheter. Yeah, the one with the catheter is going to have a greater risk. However, the patient has a catheter, they had it for a reason. So now you're not comparing apples and oranges. The risk of an infection in someone who doesn't void is much higher than risk of an infection with having a catheter. And so just getting rid of the catheter alone, if they're not peeing, is bad. And I've seen some people do that. So you got to keep the risk of a catheter of infection is real. Not trying to belittle that, but the risk of not peeing and taking that catheter out is even worse. The other common questions are prophylaxis when you have an indwelling catheter. The bottom line is there is data that says antibiotic prophylaxis with a chronic indwelling catheter is not recommended. It is not a good thing. Your event within a few weeks, you're going to get bacteria growing again, and it's going to become resistant to that antibiotic. And then you put them on another antibiotic prophylactic agent, and they're going to become resistant to that. And then again, once they have them in with a true infection, they're going to be in trouble because they're only going to be able to be treated with IV antibiotics. If you have someone who's doing in and out cathing, clean intermittent catheterization, their prophylaxis is a little more controversial. There is some data that says they do a little bit better. In my practice, we don't do it. Classically, those patients are going to be someone who may get UTIs associated with an activity, sexual activity, for example. Then we prophylaxis. We tell them when you have intercourse, take an antibiotic. And we do that with non-catheter too. If you have a female who gets UTIs every time she has intercourse, she doesn't need a workup. She probably just needs an antibiotic to be taken immediately after. And the first thing we do is we tell them to make sure you void before and preferably after intercourse to wash out any bacteria that might have been introduced. And then if that doesn't work, we put them on a single dose mild antibiotic, nitrofurantoin or something like that, to take right after intercourse, ideally before, but it's not always planned. So immediately after is fine. And that usually works. Back to catheters, if they are truly getting recurrent infections or if they've got catheter clogging, rather than try prophylaxis, we'll do irrigations because it stirs up the bacteria that's lying in the bladder and gets it to come out. So the bacterial count goes down. I start with water once a day. That doesn't work. We use water irrigation 2 or 3 times a day. And if that doesn't work, then we go to antibiotic irrigation. There is a belief that some catheter types have lower risk of infections. Actually, I didn't put it here. Silicone is purported to have a lower risk of latex. I'm not exactly sure why. Silver nitrate embedded catheters and antibiotic coated catheters, they definitely have lower risk of infections. The problem there is that they are very expensive. And if your patients are getting their catheters from any of the catheter supply companies, most of the insurances and Medicare and Medicaid won't cover them anyway. So they're not going to be able to pay for them or afford them. And on that note, I think I have a couple minutes left for questions. I hope I was supposed to go till 1:30.
You are correct. I don't see any questions in the chat box, but if anybody wants to put something there, or please feel free to unmute and ask your question. Everybody's so quiet today.
They're still like in shock from the pictures I showed earlier.
Okay, well, if there are no questions, I did put the evaluation link for Dr. Kraus in the chat box. And then also, I don't know, I can email everybody if you're okay, Dr. Kraus. I'll provide them your information in case they have any further questions.
Yeah, that's fine.
Okay, sounds good. Well, thank you so much for presenting for us today.
My pleasure. I see one. Did a comment come in?
Oh,
No.
there we go.
Oh,
Yes.
yep.
It
Some
says,
patients are using in-and-out catheter. Is that okay? That is a great question. I'll give you a long answer for that. The official answer is no, that's not okay, because the label on the catheters say one-time use. However, there have been studies that have shown that using the same catheter does not increase the risk of infection, because again, these patients are colonized. And I want to say it was 2005-ish, early 2000s when this all came about. Because prior to that, especially when I trained, if I had patients that were were capping themselves 4 times a day, they would get 4 catheters a month. And they would start their day with 4 clean catheters. We would teach them to wash them in soap and water the day prior, lay them out on a paper towel, and the next morning you take each clean catheter and you put it in its own little sandwich bag, a Ziploc bag, and you start your day with 4 catheters in a Ziploc bag. You use your catheters, you shake them dry, you put them back in the Ziploc bag so they don't get anything wet or smell. And at the end of the day, you've got 4 dirty catheters. You wash them in soap and water in a pot, and then you lay them out and you rinse them, and then you lay them on a paper towel and you start the next day all over again. And patients did fine. People were concerned about infections, and there were some nursing journals articles that showed they do not have an increased risk of infection. You would think, well, that should be evidence to say then you don't need to use a single-use catheter. What I was told is that the single-use catheters, if you look at their labels, they say single use only on it, which creates a liability concern. And then that's the reason why we all use single-use catheter. My favorite story is I take care of a lot of spinal cord patients, and they do in-and-out cathing a lot. And I had one patient who was doing it using the same catheters, like I said, 4 catheters a month. And he started getting these boxes and boxes of catheters shipped to him. And at one point he goes to me, can you get them to stop sending me catheters? My garage is full of boxes of catheters, because he was still using 4 catheters a month. So I hope that's your answer. Officially, the answer is you should not reuse the catheter. I do tell my patients if they're in a pinch and they don't have a fresh sterile catheter, they can reuse it, just recognizing that they're doing it off label and such. Not uncommon when I've got patients who travel, especially if they're traveling to some countries where they may not have easy access to catheters, they didn't bring them or didn't supply them, they'll do that as well.
any other questions? All right, I don't see anything else. So with that, thank you again so much. And thank you everybody for joining us today.
Have a good day, guys. Thanks for listening.
Thanks. Bye.